first session here on the coagulation, and I welcome my co-chairperson Dr. Daniel, and we have three sessions, three lectures in this session. One is on state of art lecture, optimal anticoagulation monitoring during CPB by Dr. John Benz from UK, and second lecture is on heparin resistance, how I manage it, by Eric Benedict Leinberger from Brazil, and the third lecture is on hemostatic agents in cardiac surgery, current evidence by Dr. K. Nedumaran, senior cardiac anesthesiologist from Chennai. So we'll start with the first lecture. Dr. Benz, are you online? It's not online. Shall we proceed with the lecture? You can put on the
from Leicester in the UK. It is a great honor and a privilege to speak at this prestigious meeting. I would like to thank the organizers for inviting me. I'm going to speak to you today about the optimal anticoagulation monitoring during cardiopulmonary bypass. I'm going to speak and we will look at a couple of things, what we could be doing, and we look at state-of-the-art and developments taking place at the moment. I'm just going to speak to you about this and use the guidelines. Anticoagulation cardiopulmonary bypass been around for a long time, but nobody wrote any guidelines or any recommendations until the SCTS, SCA, and SEC brought out this under the leadership of Linda Shaw-Lesterson. And for the first time in 2018, followed closely in 2019 by the European groups of the same commodities, more about bypass, but with a little bit around the anticoagulation. So just let's look, where are we coming from? What we're using heparin, we've got to think about this. It's actually quite funny. Are we still practicing witchcraft? Are we running around fires with pointy hats? Because heparin, although discovered in 1916, is just a glycosaminoglycan or a mucopolysaccharide. It's basically mucus. It's pig mucus, and we use mostly porcine because of the CJD scare for bovine. And so most of the heparin around are porcine. Just a reminder of how it works. The unfractionated heparin that we use bind with antithrombin, antithrombin 3 particularly, and it binds from the thrombin and the factor 10A to immobilize your coagulation system at that level. And this is important because these are the things that we need to measure to monitor anticoagulation. The next is even worse, is that the protamine, the big factor that plays a role is protamine, small albumin-rich protein, but comes from salmon sperm. It was FDA approved already in 1969. And protamine as such neutralizes heparin, but it also does a lot of damage to our overall coagulation. So in itself, it's an anticoagulant. So this is one of the other factors that we use. That's very, very primitive. Then the ACT, and you can see this is our gold standard, which we measure everything against. But it's basically just the time we measure, and you can see where it comes from. With bull, which is basically initially just activated blood with saline, and then measured in a very primitive way by shaking it and eyeballing when the clots are forming. And then you must remember where this saline came from. It's diatomaceous earth. It's considered as a skeletal remains of single-celled algae and diatoms formed due to sedimentary deposits. So what we are doing is we are actually measuring, we're taking big mucus to anticoagulate patients. We reverse that anticoagulation with salmon sperm, and to what we're actually supposed to monitor. These are all the factors that play a role. And this is, if you think about Donald Rumsfeld's speech about the known unknowns and the known knowns and the known unknown knowns and things like this, these are in the same category where we work with controllables, uncontrollable controllables, and controllable uncontrollables, and these are all the factors that we actually should keep in mind. If you look at the guidelines are, these are the European guidelines that just say the ACT should be above 480 seconds if we use uncoated equipment, and cardiotomy suction, so it's also equipment dependent. We should individualize heparin and protein management to the cardiopulmonary bypass. If we don't have individual heparin dosing tools, it's recommended that the ACT test be performed at regular intervals, which is something that we all should do. The protamine management, it just says we should avoid protamine overdose, and we should use that in a certain relationship with the heparin that we take. And then it discusses alternative anticoagulation, and we'll just quickly touch on these to show how to monitor it. And the first thing I said that bivalirudin is a reasonable replacement, and argabatrin is a reasonable replacement. The American guidelines just look at three areas: the heparin dosing and monitoring, and the heparin contraindications and the alternatives, and also the reversal of anticoagulation, how you should reverse it. So let's look at what we do. And this is according to this SCA guidelines that we had, and this is a survey that's done. What does our members do? This is 80% of these respondents were in the UK, in the USA, but it actually includes people from all over the world. So let's look at what our traditional approach is, what we should expect. It's 300 to 400 units per kilo of heparin to go pre-night. Maintained at about 400 to 480 seconds, your 5,000 to 10,000 unit boluses of heparin. Then at the end, reverse with protamine on a 1 to 100 units basis, and then give additional protamine to achieve the ACT to plus minus normal values of about 120. So what are we in reality doing? What are people doing? This is, you can see here, 75% just use the normal empiric weight-based dose heparin, so just give heparin per kilo. 84% does add heparin to the circuit. 70% target an ACT of 400 to 480 seconds. You can see here is a graph of the spread of the heparin boluses, and here's the spread of the ACTs that people expect. So 84.7% assessed adequate anticoagulation by targeting a specific ACT for initiation, and 88% looks at the target during cardiopulmonary bypass that they have the ACT around about 400 to 480. Only 13.1% uses the heparin level and the ACT to determine adequate anticoagulation for initiation of cardiopulmonary bypass. Only 6.7% actually maintain a specific heparin level. So look at the blood heparin levels during cardiopulmonary bypass. 17.1% use an ACT lower than that is recommended, or they didn't monitor the ACT at all. And then just for 54% administered antithrombin concentrates as first-line therapy in heparin resistance, which is more in line with the next talk rather than this one. So this, what we all use and how we should monitor, and what we are looking at the moment is the ACT devices that we use. They vary considerably. There's a lot of studies that you can have a look at, and that show that because of the measurement platforms, different activators, different sample volumes, and sensitivity to hemodilution, hypothermia, and other drugs that are used, they vary considerably. And we'll see later in a graph that we can show how just two of these devices give us completely different levels. They correlate poorly with the heparin level as assessed by the anti-10A plasma activity. We'll come back to that a little bit later. The ones that use a maximal activated sample have got less variability to clotting times, and also they are less susceptible to the prolongation by hypothermia and artifacts. The maximal activation you actually achieve by these microcuvette ACT technology because of the small sample volume and the minimization of the sample dilution. And there are new viscoelastic measurement of ACT that actually mirror the activity much better of these devices. The next device that actually plays a role, and it should play a bigger role, if the pen is the heparin protein management with the HepCon, measuring the heparin levels. We should have the heparin levels more around about 4 units per mole. This correlates much more with your factor 10A, and it actually has got, you use much more heparin if you use this, and there's much less damage to your clotting factors. And it has also got an effect on post-operative transfusion. But there's a problem inherent in the measuring with the HepCon device. There's 6-channel cartridges, and these cartridges contain certain concentrations of protein. In the channels with higher protein, no clots because protein prevents clotting. In channels high heparin, no clots because the heparin prevents clotting. In the balanced channel, yes, there is some clot, but the gaps between these channels are 0.7 microgram per mole. So it gives you an imprecision error of about 10%. So in a target concentration of 4 units per mole, you'll find that you can have anything between 3.6 and 4.4. And the blood volume alone plays a big part. We forget that the blood volume in patients and for different pathologies vastly differ. For instance, patients with aortic stenosis and CABG, the blood volumes of more or less around about 45 moles per kilo, whereas for patients with mitral valve, it's about 70 moles per kilo. And with mitral valve and tricuspid valve, it's more than 70 moles per kilo. Factor 10A will be probably the gold standard for measuring the anticoagulant effects of heparin. And this is by inhibition, as you can see here. This is mostly a laboratory assay, and it's used mostly chromogenic. So, but they are going to, this is important, point of care assays for factor 10A is becoming available. And you can see how closely factor 10A actually correlates with the levels, the heparin levels. These two are two different, one's Chiron, one's pectin measured ACTs. Actually, as you go on bypass, actually have got no correlation with the heparin levels and the factor 10A levels in the blood as such. So this is an important thing. Just a quick look while we have around here at alternative anticoagulation, how to monitor this. Obviously use alternative anticoagulation when heparin is contraindicated. But HIT and true sensitivity to heparin is severe protein allergy. And you can see this is actually even further into the past using bleach products, snake poison and everything. But the two most important are bivalirudin. So bivalirudin we can monitor with the heparin clotting time, which is not available as a point of care test, but ACT was found to have an acceptable correlation. So we can use two. Okay, good morning everyone from Leicester in the UK. It is a great honour and a privilege to speak at this prestigious meeting. And I would like to thank the organisers for inviting me. I'm going to speak to you today about the optimal anticoagulation monitoring during cardiopulmonary bypass. And I'm going to speak to you, we're going to just talk to you where we're coming from, what we should be doing. We'll have a look at the guidelines and the recommendations. We'll have a look at the SCA survey that ACT was found to have an acceptable correlation. So we can use 2.5 times the baseline activated clotting time. For reversal, you've got to wait because of the short half-life of bivalirudin. You can use modified ultrafiltration, hemodialysis, or you can give recombinant factor 7A, or you can give products as much as you like to reverse it. Gaptoban you have to have the ACT around about 500 to have it. It's got a longer half-life of 40 to 50 minutes, and it is used mostly in patients that have got impaired renal function, because it is mostly hepatically cleared. But it's got a longer half-life, so afterwards you've got to be patient with these patients. But you can use the ACT, but you can also post-operatively use the PTT to monitor the patient. Just a couple of notes about the protamine reversal and how to measure this 1 to 100 traditional reversal. We must remember that if we get to a ratio of more than 1.3 to our initial heparin dose, we are going to get associated with coagulation abnormalities. ACT measurements are the worst to use a protamine reversal and to monitor protamine reversal, and so the main usage here is point of care testing using the protamine titration of the heparinized blood samples, such as the HepCon or our much reliable TEG to measure this. Just that you measure the reaction time, as we all know, is a measuring of the clotting factor. The kinetic time is a measuring of the speed taken to reach a specific level of clot strength. Alpha angle measures speed of the fibrin buildup, maximum amplitude, the strength of the clot, and the platelet function, and the LY30 looks at the breakdown and the stability of it. A routine coagulation test haven't got a big role at the moment. They are becoming available as point of care clotting, the bedside tests, and they will become more and more important and more available. Just a note here, the platelet count, preoperative platelet count, and the fibrinogen levels are the only real predictors of the post-operative bleeders that we've found so far. Thromboelastograph versus the routine coagulation test. Just a couple of notes here that you can see again that the platelet count among the bleeders was 26% less. Baseline fibrinogen again was lower in the bleeders, and post-operatively it was even more lower. The TEG parameters showed a significant correlation with blood loss. And the bleeders, the R time and MO had a correlation with bleeders. No RCT, no routine coagulation test was found to be able to predict the blood loss. The alpha angle and the MA had a significant correlation with fibrinogen, and there's a strong correlation between MA and platelet count. A couple of examples just for you, just to revise the TEG. TEG versus ROTEM is not very important. You just do not use algorithm developed for one device with another. TEG, the cup rotates, and ROTEM, the pin rotates, and you've got different parameters that you measure. The platelet function tests are important. A lot of them are becoming available. They can detect platelet dysfunction, and it's important to incorporate them into our blood transfusion algorithms. And you can see here that if you use a point of care platelet function test and plus your TEG and your ROTEM, it does reduce your blood transfusion requirements quite a lot. You've got to monitor fibrinogen and fibrinolysis. There's a whole blood point of care fibrinogen assay that's available with the Hemostatic systems that are available at the moment. It's a good predictor of bleeding before, and if you can see that even a little bit of lowering in fibrinogen concentration bring your clotting time up quite badly. Your TEG and ROTEM is slow to predict your fibrinolysis, and look at that. And your fibrin degradation products are all latex agglutination assays that takes a long time. D-dimers is also a good measurement that you can use, but it takes a little bit of time. Specific coagulation factor deficiencies in tests, it's better to know where you're coming from. before, going your history of your patients, and these are shotgun tests, and they will be prolonged at the end of your operation. You've got to be suspicious in certain pathologies, like acquired convalescent and aortic stenosis. And point of care tests are becoming available, because mostly serum tests at the moment. You've got to remember, you actually have to monitor and control all of this to look at and make decisions. So it's not just what happens intraoperative. Just going to summarize what is useful according to our evidence. Pre-op and pre-cardiac pulmonary bypass is your platelet numbers, your function of your platelets, and your size of your platelets, your fibrinogen levels, your antithrombin 3 levels, and your history of your patient. Intraoperative and post-cardiopulmonary bypass, your ACT and your heparin levels are important. Your TEG and your TEG-ROTEM plus your platelet function point of care tests, and your indicators of fibrinolysis. I thank you very much from Greenfield Hospital in the UK. Thank you very much.
Thank you, Dr. John, for your elaborate description of optimal anticoagulation monitoring during CPB. Welcome, Dr. Lindberger.
Thank you.
Yeah, we welcome you to deliver your lecture. We thank you for participating in this conference. Yeah, we'll proceed with the lecture now.
Okay, the honor is all mine. Thank you.
Dr. Lindberger will be speaking on the heparin resistance, which is a very important topic.
Hi everyone, my name is Eric Benedetto Lindberger. I'm an anesthesiologist from Brazil. And first of all, I'd like to thank you very much for this invitation in this great event, in this great scientific event in anesthesiology. And my talk is going to be about heparin resistance and how I manage it. And in the next few minutes, I'm going to talk about heparin mechanism of action, identification of heparin resistance, diagnostic tests that we use to monitor coagulation with unfractionated heparin and make some difference between them, prediction of heparin resistance, a little bit about this issue too, but most important, review treatment options and management, along with a proposal for point of care strategy for management that we possibly can use in our institutions, and finish with some conclusions. Some important chemical properties of heparin that I show here, which is a negatively charged molecule and is isolated from porcine intestine in mast cells. There's a difference in weight between unfractionated heparin and low molecular heparin, that it's in the range of thousands of Daltons. So low molecular heparin, it's a purified polymer that's more uniform than unfractionated heparin that we mostly use in cardiopulmonary bypass, the unfractionated form. Primary mechanism is catalyzing antithrombin, factors 2A, 10A, and other factors. So here we begin to see some problem because it's not a direct mechanism. It depends on a cofactor for its mechanism of action. And we can see perfectly in this diagram of the coagulation pathway that when heparin is bounded to antithrombin 3, it catalyzes the inhibition of factor 10A and factor 2A, which is thrombin. That's the center of the problem here when we talk about CPB. So it increases inhibition several times, several thousand of times actually. Another mechanism of action would be to catalyze the anticoagulant properties of cofactor 2, but not so important as this action in factor 10A and factor 2A. To further complicate the action of heparin, this molecule, heparin, needs to have a specific chain sequence and length to correctly link to antithrombin 3. Otherwise, it gives rise to another forms of mechanism of action to ensure anticoagulation. The fact is that only 1/3 of these molecules of heparin possess this correct sequence of polysaccharides. So it further, as I said before, complicates the mechanism of action and the pharmacokinetics and pharmacodynamics of heparin. The pharmacokinetics of heparin is complex and variable during cardiopulmonary bypass. There's basically two types of clearance in cardiopulmonary bypass: a rapid saturable, that's through endothelial cells and macrophages that internalize the molecules of heparin, and another is lower, non-saturable, by elimination through the kidneys. So higher dose can increase both intensity and the duration of the anticoagulation effect. So I can exemplify here a dose for 25 international units per kg, reaching to 400 international units. It can lead to differences in duration of effect ranging from 30 minutes to 150 minutes. So one can imagine how a dose of 1,200 international units per kilogram in this patient that has difficulty to get to a correct anticoagulation, to get into CPB, can ensure in the post-operative period in terms of bleeding. So it's a huge problem, and we have to better understand this mechanism, and it's one of the reasons that this lecture is important. So let's get to the point. Identification of heparin resistance. The definition is quite simple: the need for high heparin doses to achieve a targeted level of anticoagulation. The problem is that there is a lack of consensus to get to this diagnostic issue. In cardiopulmonary bypass, the general incidence ranges from 4 to 26%. A more specific definition would be a dose more than 500 international units per kg of body weight to achieve an anticoagulation time of 400 to 480 seconds. Let's talk now about diagnostic tests. The activated partial thromboplastin time. It's a useful monitor for unfractionated heparin endovenous in the range of concentrations in plasma from 0.2 to 0.8. Citrated patient plasma is added to calcium and phospholipid with a reactor, kaolin micronized silicoyl acid, which gives a result number in seconds. The time from recalcification to the formation of the clot is measured, as I said, in seconds. So it's a log linear fashion in low concentrations and a non-linear fashion. This reaction gives rise when heparin is in high concentrations in plasma. It interferes too with factor VIII and fibrinogen. So APTT is a problem with high heparin levels, as we can see, so it precludes its use in CPB. The activated clotting time, ACT. This action begins with activation of the contact system when we add a reactor like Celita or kaolin into a sample of whole blood. It can monitor high levels of heparin, ranging from 1 to 5 international units per ml, in contrast to APTT, that's unable to read these concentrations. That's why it's especially useful in CPB, but it's subjected to patient variables, especially happen during cardiac anesthesia and cardiopulmonary bypass, like hypothermia, hemodilution, antiphospholipid antibodies, protamine, and several others that are beyond the scope of this lecture. But one can realize that prolonged ACT time can happen in these situations. Chromogenic assays, substrates cleaved by the activated factor. It uses synthetic chemical substrates, and these substrates are cleaved by the activated factor. So when we talk about 10A assays, we have a plasma citrated of the patient that is added to the factor 10A. So the anticoagulant inhibits the factor 10A and decreases its activity. So it produces a result that's inversional proportional of the level of anticoagulation. It can monitor unfractionated heparin in the clinical range of APTT. It's not influenced, for example, by factor VIII, and it is used when it's a situation of inaccuracy of ATTP. And in that situations where we have ACT that's prolonged because of several patient factors. Most of the time we don't have this dynamic time situation in the room to measure this, to get to conclusions and to take actions in relation to heparin resistance during CPB. One can use heparin dose response curve and concentration monitoring. There are several monitors that are useful to predict the dose of heparin based on the concentration in the plasma that industry developed. They're based in the assumption of this curve that I showed here. Once we have a sample of blood from the patient without heparin, we add heparin in vitro, and we have the anticoagulation clotting time. So beginning from this result, we can construct a curve that we can extrapolate to reach the target for CPB. This in the left are formulas that use heparin concentration and formulas that use heparin bolus dose. Even without monitor of heparin concentration, we can predict this target. This guidelines from 2018 from the STS, SCA, and the American Society of Extracorporeal Technology show some evidence about what we expect about the modalities of monitoring of heparin during CPB. I will resume the most important evidence-based recommendations that are in accordance with the subject of this lecture. The first, it's that it's reasonable to maintain activated clotting time above 480 seconds during CPB. It depends on the instrument being used. I will talk after that for most instances, there is a lot of variability between institutions regarding the target of the ACT. Most of these numbers are in excess of safety margin, so it's useful in situations where we have heparin resistance. Just to point here, as I said before, the recommendation is use a maximally activated exam of ACT to be in parallel and reproducible with the 10A activity. Heparin dose response formula helps to find us a patient with sensitivity reduced to heparin, but when you put evidence into this approach, you have a class 2B recommendation, as long as heparin concentration monitoring could be useful to monitor the plasmatic concentration during CPB, but comparable to re-administer heparin based on ACT during cardiopulmonary bypass, it seems to be in the same level of evidence. So it's not a great grade of recommendation here, and we know that not all of the institutions have available these monitors and this approach. When we are facing heparin resistance, we almost immediately think about antithrombin deficiency. So one can have in mind that there are a lot of causes for this deficiency, like hereditary ones, reduced synthesis, accelerated clearance, like in nephropathy, accelerated consumption, like in CIVD, CPB related to the membrane oxygenator, to, for example, ventricular assisted device. There are several causes for this deficiency, as I said, and it's again beyond the scope of this to list all of the cases, but we must keep in mind that there is a related cause of heparin resistance to antithrombin and an unrelated one, because heparin binds to several proteins, endothelium, platelets, and thrombophilia. It's a real situation. Nitroglycerin, not so great at this, but okay, and lately COVID-19 patients, which showed this frequently resistance of heparin in the ICU admissions. So, what are the reasonable steps to follow when I face a case of heparin resistance? Classically, there's 4 options: additional heparin, antithrombin 3 supplementation with fresh frozen plasma or with antithrombin concentrate, or the least reasonable one, proceed with CPB. The decision to proceed with CPB is often based in that institutions that use high target of activated clotting time. So it tends to have a great margin of safety to lower the trigger of ACT. The logical first step is to administer additional heparin. We must know that heparin is bound into proteins, endothelium, and there's a ceiling effect of it's almost a constant number in the papers, 4 international units per ml. If we get to this point, there is no sense in doing more heparin because ACT will not respond so well. So part of the whole blood concentration heparin could be a place in this situation, although we don't have so much evidence as I showed before in that wide lines showing that it's a 2B class of recommendation. What we can see here in this survey of the members of the SCA, showing that some colleagues really extrapolate these doses, but almost the majority don't use these high doses when faced with these situations. Supplementation with fresh and frozen plasma to restore the antithrombin levels. 1 unit of fresh and frozen plasma has, in average, 1 international unit of antithrombin per ml. So 2 units of fresh and frozen plasma has been historically used to reach this goal, but there is controversy in results. Some papers showing that there's no restoration with this of the ACT values using antithrombin associated with fresh and frozen plasma. But other papers are showing that it can restore, so it's a reasonable option in view that not all the institutions have available the concentrates of antithrombin. There's problems when we use fresh and frozen plasma, mostly related to the possibility of viral infection and related to inflammatory consequences, especially the transfusion-related acute lung injuries. So there's a problem too with delay to ensure tau infection time. Obviously, the concentrations on it per se has some advantages over fresh frozen plasma, mostly related to the purification of the solution, of the lyophilized solution. There's more data on efficacy of this administration, and the dose is between 500 and 1,000 international units, being 1,000 mostly used by the authors. Here are some examples of papers when we compare concentrates of antithrombin 3 with fresh and frozen plasma. We have reached here much more concentrations in the plasma of antithrombin, and so restoring with much more efficacy the levels of ACT. And one interesting thing is that when we use extrapolated dose of antithrombin 3, repeat the dose, maybe we have a mechanism that's independent of the heparin in the anticoagulation, so it might be a possible explanation for the superiority of this supplementation with the concentrate when we compare to fresh frozen plasma. I thought very interesting to show this paper, beyond the fact that the authors restored in patients with heparin resistance the ACT, the patients didn't have much difference related to postoperative bleeding, and above all, I think the goal-directed protocol that the authors use could be updated form for us to conduct bypass when this problem of heparin resistant issues in the intraoperative phase. The authors used a goal of 400 international units per kilo of body weight with ACT more than 500 seconds per CPB to define the heparin resistance, and using a goal-directed approach that I'll show next. I found this to be a very informative goal-directed protocol, and is quite updated from 2021. The authors used the first ACT less than 500 seconds, and that definition of heparin resistant that I showed in the slide before, and administered between 5,000 and 10,000 international units of heparin. Then a second ACT was performed if below 10% of the target. Additional heparin, the same dose, was used. In the third ACT, if continues to be out of target, then yes, the antithrombin concentrate was used in a dose of 1,000 international units. So the target reached. As soon as the target was reached, they commenced the CPB and measured ACT 3 to 5 minutes later. During CPB, if the ACT drops to less than 500 seconds, additional heparin, even after 83 supplementation, was administered, and after that, the next ACT continues to be less than 500 seconds. It was at 8 thrombin 3 concentrates to the CPB venous reservoir. Consider and discuss with surgeon additional antithrombin 3 and repeat the steps. You can substitute this for fresh and frozen plasma if the institutions don't have the concentrate, but the important is this is a goal, this is a protocol, and I think every institution has to develop something like this. Maybe the rationale to use more antithrombin 3 would be that your mechanism independent of heparin that that is shown in some papers when compare the superiority of antithrombin 3 against fresh frozen plasma. This is a great problem when you have done all that's available to ensure ACT and heparin concentration is high. What do you do? In the survey of the SCA, that one that I showed before, 0.1 to 1.7% of the responders initiate the CPB anyway, and this is a very empirically and hard task and decision to do. You have to discuss with the surgeon, you have to see the consequence, you have to realize about the emergency of the situation, and you have to see possibilities to avoid the case or convert it, if cabbage, to off-pump surgery. Well, there's a tough situation, perhaps not common thing to happen in the intraoperative. In this thought, we can see that issues about safety of minimum ACT, it varies with institution. In that empirical decision that I just said, it's all about knowing about the target that the institution will use. If you use a safety margin, a high margin, you can use a more conservative approach, and you see by the responders of the same survey that in the initiation of CPB, some of them can use, and they say in their case reports that they're performed a safe CPB with these numbers of 350 or even less. Finally, take-home message: there's not yet an ideal anticoagulant for CPB because it depends on a cofactor. Accumulated experience shows us the best way to get around these limitations. Have a defined institutional action plan for heparin resistance is one of the best attitudes in promoting patient safety. Thank you very much. Thank you again for the invitation. It's an honor to be part of this great conference with high level of scientific content. Thank you very much.
Thank you, Dr. Lindberger. We also welcome Dr. John. Thank you, Dr. John, for coming on at this odd hour and delivering the lecture. Okay, we'll proceed with the next lecture. That's by Dr. K. Nedimaran. He is senior consultant at Dilrath Hospital in Chennai, very active member of IACTA and a good friend of mine. He is going to speak today on hemostatic agents in cardiac surgery, the current evidence. Dr. Nedimaran.
Thank you, sir. Good morning to all. Thanks for the introduction to Dr. Raju, sir, Dr. Daniel. Thanks for the organizing team for providing the opportunity. This is an IACTA first time we are conducting the hybrid conference, both physical and virtual. Similarly, this is the only session I think both physical as well as virtual. So we have seen the virtual, now physical above. Complications from uncontrolled bleeding are both costly to the patients in terms of outcomes as well as to the healthcare system. Selection of proper hemostatic adjuvant can reduce time to hemostasis, reduce blood product transfusions, and improve patient outcomes. No hemostatic medication is efficacious unless otherwise if you take care of the surgical bleeding. How will you manage the surgical bleeding? They will use the thumb, clamp, suture, resection, packing. They will use topical hemostatic agents, blood products. As an anesthesiologist, we will be concentrating more on the topical hemostatic agent selection as well as in the blood product transfusions. Let us see now. Coagulation simplified. This is a primary hemostasis, secondary hemostasis, fibrinolysis. If you want to lyse the clot, or if you don't want the clot, what will you do? We'll use antithrombotic, we'll use here anticoagulant, we'll use fibrinolytic. If you want the clot formation, want to stop the bleeding, how to go about? There are some therapeutic options, acts at different level: fibrinogen, cryoprecipitate, desmopressin 1 milligram factor, PCC, prothrombin complex concentrate, factor 13, antifibrinolytic like tranexamic acid. If you see, cryoprecipitate plays a role in all the place. Why? Because cryoprecipitate contains factor 8, 1 milligram factor, fibrinogen, factor 13 and fibronectin. Each unit contains 10 to 15 ml. So for 1 unit of cryo per 5 kg they will calculate. So most of the institutions, they use approximately 10 units. They will reassess and they will again they will use the cryo if necessary. In United States, maximum they use cryoprecipitate, but in other European countries they use fibrinogen more. When I searched the literature why they are using cryo in US alone, then we found that there are a lot of hemophilia patients in United States where this cryoprecipitate helps than the plain fibrinogen. We'll see the procoagulant interventions. As the recommendations, antifibrinolytic therapy to reduce bleeding and transfusion of blood products and reoperations of bleeding. It's a class 1A recommendation. That is, tranexamic acid, epsilon aminocaproic acid usage is recommended as class 1A. Class 1 evidence, A level B. Next, in patients where bleeding is related to coagulation factor deficiency, either FOB or PCC should be considered to reduce bleeding and transfusions. Class 2A, level B. Bleeding patient with platelet dysfunction due to inherited or acquired bleeding disorder, desmopressin should be considered to reduce the bleeding and transfusions. It is class 2A, level C. Here it's a platelet dysfunction, not the quantification. Class use of PCC, prothrombin complex concentrate or FOP may be considered to reverse vitamin K antagonist. Patients with factor 13 activity less than 70% after cardiopulmonary bypass, administration of factor 13 is considered to reduce the bleeding. Bleeding patient with the fibrinogen level less than 1.5 gram per liter, fibrinogen substitution may be considered to reduce the bleeding and to reduce the number of transfusions. Patients with refractory non-surgical bleeding, off-label use of recombinant factor 7A is considered to reduce the bleeding. These are all comes under class 2B recommendations, level B. There is no prophylactic. There is no role for the prophylactic use of FOB, fibrinogen, desmopressin, recombinant factor 7A. This all comes under class 3 level B. Transfusions. Pooled solvent detergent treated FOB may be preferred to standard, which we are normally use the FOB, because it reduces the risk of trally. Not only the trally, the infection also, the transmission of infection also is reduced in the solvent treated FOB. It's a class 2B and level is B. Platelet concentrate should be transfused in bleeding patients with the platelet count less than 50,000 or patients on antiplatelet therapy with the bleeding complications. It's class 2A level C. Another important thing is here, they are recommended to transfuse packs RBCs on the basis of clinical condition rather than on fixed hemoglobin threshold. That means earlier they used to transfuse, threshold will be, they'll keep like hemoglobin is 6, 7, 8, something like that. So 18, they'll keep the third thing. Now suppose preoperatively the patient hemoglobin is 16, 17. Will you allow the patient to drop the hemoglobin up to 7 or 8? Because more than 50% reduction of his hemoglobin. So what the recommendation says is, according to the clinical condition rather than the fixed hemoglobin threshold. It's a class 1B. This is a 2005 British Journal of Anaesthesia picture. It's a blood clot, it's a non-diluted one. Here this is diluted with 65% with the gelatin. This clot shows after administration of fibrinogen. This is just to show how the clot formation is enhanced by the administration of fibrinogen. Recombinant factor 7A, as I already told, most of them are off-label use but expensive. Dose is 90 to 120 microgram per kg. If conventional therapy failed in treating the local bleeding or diffuse bleeding, most of the place they will use a recombinant factor 7A. But we have to be very careful in cardiac CABG patients. It's a thrombogenic, so we have to be very careful in CABG patients. FOB, earlier they used to give 10 to 15 ml, now 15 to 30 ml per kg body weight. Complication is immunomodulation, acute lung injury, cardiac overload. So, it's algorithm on DHA. We recommend the application of intervention algorithms incorporate predefined triggers and targets based on DHA. It's a class 2A level B. If DHA is not available, then we should have the algorithm based on the conventional coagulation test. So we have seen about the blood products and the recommendations. Now we see the topical hemostatic agents which we commonly use, because this is the area which we need to know more about, because we are reading about the blood products but we are not known much about the topical hemostatic agents. We'll go ahead. Frequently, selection of topical hemostatic agent has been constrained by anecdotal experience and limited knowledge of the diverse array of agents presently available. Choosing a hemostatic adjuvant relies on understanding of its mechanism of action, indication for use, and knowledge of potential complications surrounding its use. Most of the times, the origin is from a human, animal, or synthetic. If it is a human, most likely transmission of infection is the concern. If it is an animal origin, immunogenic reaction is the concern. If it is a synthetic one, allergic reaction is the concern. These topical agents are classified into mechanical agents, also called passive agents, active agents, flowables, fibrin sealants, others like butyraldehyde, cyanochryldates, PET polymers. We'll just see one by one. These mechanical agents or passive hemostatic agents form a physical lattice-like matrix that adheres to the bleeding site. This matrix activates the extrinsic clotting pathway and provides a platform around which platelet can aggregate to form a clot. Because it relies on fibrin production for use in patients who have an intact coagulation cascade. Used as a first line agent in most of the place because it is immediately available, require no special storage or preparation, and relatively very inexpensive. What are the things we have? We have a porcine gelatin origin from porcine, origin from bovine, oxidized regenerated cellulose, polysaccharide spheres, bone wax. We'll just see. So mechanical agents, porcine origin, gel foam, surgifoam. Gel foam, surgifoam which we are using is from as a mechanical agent, it is of porcine origin. Here it is ultrafoam, avitine, instat. These are all bovine origin. Here oxidized cellulose, surgicel fibrillar. This also we commonly use, but how the oxidized cellulose acts? It comes as a powder as well as fibrillar sheet to aid in providing local hemostasis from capillary or minor venous bleeding. Once saturated with the blood, it swells into a brown-black gelatinous mass because it decreases the local pH and lyses the red cells, and then it absorbs that one. It serves as a scaffold for platelet aggregation and is generally absorbed completely within 4 to 6 weeks. Advantages of being something bacteriostatic effect. The key disadvantages of surgicel is that by lowering the local pH only it is acting. So when you are giving other hemostatic agents like thrombin, it may be rendered inactive. So when you are using oxidized cellulose, surgicel fibrillar, you have to be very careful whether you are using thrombin because you have to clear the field before applying other agents like thrombin. Mechanical agents, other one is a polysaccharide spheres. Arista is a powder form. It comes prepared from the plant starch. This one acts rapidly by dehydrating the blood, causing the MPH, this microporous polysaccharide, to swell and concentrate the blood solids such as platelets, RBCs and coagulation proteins to form a gelatinous matrix which creates a scaffold for formation of the fibrin clot and provides a mechanical barrier to the continuous blood loss regardless of the patient coagulation status. It typically is degraded by serum amylase within 24 to 48 hours. Next comes the bone wax. Bone wax every day we use. It was first classically described in 1885. It contains bee wax, almond oil, salicylic acid once upon a time. Now it contains a petroleum product, paraffin, with isopropyl palmate. So since it is a petroleum product, it is inert, it was not absorbed, it is not degraded. So what happens because of that? So it significantly reduces the number of bacteria needed to initiate infection. For this reason, bone wax should never be utilized in a contaminated field. There is a high incidence of bone mediastinitis as well as osteomyelitis with bone wax usage. There is an alternate for the bone wax. It's called Austin. It is a water soluble one. It eliminated from the bone surface within 24 to 48 hours of applications. So we should know what we are using, whether it's the bone wax or the recent one like that, because the bone wax is with higher incidence of mediastinitis, osteomyelitis. Now the Austin is degraded within 24 to 48 hours. It is an alternate to the bone wax. We have seen about so far the mechanical agents are passive agents. Now we'll see about the active agents. What do you mean by active agent? If it contains thrombin, it is an active agent. It requires, once thrombin, you already seen the coagulation pathway, thrombin will convert the fibrinogen to fibrin. So you are giving thrombin. It requires the presence of circulating fibrinogen to actively convert it into fibrin at the bleeding site to produce a clot. Of course, if there is no fibrinogen, it doesn't act. In clinical condition A, fibrinogenemia, it will not act. Thrombin should never be injected into the bloodstream or allowed to enter the bloodstream through large bore blood vessels, because once thrombin gets into the circulation, it activates the fibrinogen to fibrin. So clot formation happens within the system, which can be fatal. You say have a very rapid onset of action within 10 minutes in most of the patients. So again, based on the origin, if it is a bovine plasma, the thrombin origin is bovine plasma, the brand name is thrombin JMI. Erythrom contains human thrombin, Ricothrome contains the recombinant thrombin. It is from Chinese hamburger ovary cells. Thrombin, when compared with the gelatin component, the sponge is capable of absorbing 45 times its own weight, expanding to nearly 200% of initial volume and facilitating concentration coagulation factors in the area of concern. Okay. What we are using? It's a erythrome, recothrome. Erythrome is a human origin. Recothrome, as I told, is a recombinant thrombin. So this is about the active agents. Next comes the third headings, flowables. The flowable hemostatic agents contain a passive as well as active hemostatic agent, a single application product. As a result, this product works by blocking blood flow and actively converting the fibrinogen into fibrin at the site of bleeding. It has a solid or pasty consistency. For this reason, flowable hemostatic agents remain in place more effectively than does the liquid thrombin alone. So, there's again bovine origin, porcine origin. Bovine origin is the flow seal, porcine origin is surgiflow. So, flow seal deliver human thrombin in gelatin-based matrix, consists of collagen microgranules to produce swelling and tamponate effect. Compared to other fibrin sealants, it requires a blood as a source of fibrinogen. Flow seal was associated with statistically significant higher rate of successful hemostasis and shorter time to hemostasis. This is a bovine origin. Surgiflow is a porcine origin. So we have seen hemostatic mechanical agents, active agents, flowables. Now there comes the fibrin sealants. Fibrin sealants consist of both thrombin as well as fibrinogen, which upon mixing with blood create a stable fibrin clot. They are typically supplied in a dual syringe system that admits both the agents immediately prior to applications. The mechanical strength of the clot is given by the concentration of fibrinogen, the rate of clot formation by the relative concentration of the thrombin. Fibronectin was a high molecular weight extracellular matrix glycoprotein that is physiologically deposited at the site of injury. Along with the fibrin, serves as a sealant to aid in wound healing. Fibronectin is also will be there. So fibrin sealants, localized and diffuse bleeding is indications. If it is a human plasma derived fibrin sealants, the trade name is TCL. Most of the place we will be using TCL. It's a human plasma derived things. Suppose if you want to use patient's own plasma with bovine collagen thrombin, there is a cryocell system which uses patient's own blood to create the thrombin. TCL is commonly used. Others comes now glutaraldehydes. This glue, bioglue is the trade name. Glue is not a gum or something like that. This is a glutaraldehyde. Glue means glutaraldehyde. It's a glutaraldehyde with 45% serum albumin. It's a bovine origin. So this glutaraldehyde chemical cross-links the residues of proteins in the bovine albumin to the cell proteins at the wound site and form a tough scaffold to which the clot can adhere. The product has 65% binding power within 20 seconds of application and obtains full strength in 2 minutes, regardless of temperature, whether the product is applied in the environment of air, water, whatever it is. So it's densely adhered to the wound site. Next comes synthetic polyethylene glycol polymers. The trade name is CoSeal. CoSeal is a combination of two PEG polymers that can be sprayed or put on the tissue to form a synthetic hydrogel matrix. The polymers cross-link to each other and to the contact tissue also. This cross-linked network then forms a sealant to tissue fluid as well as a barrier to the cell growth. It is widely used in the vascular as well as cardiac procedures. Okay, what is the recommendations? Based on the available evidence, the routine use of topical agents in cardiac surgery is not recommended. May be considered in case of persistent bleeding where the bleeding is localized. That means may be is to be recommendations. Similarly, the Society of Thoracic Surgeon Blood Conservation, that they also given the recommendations class 2B, but however, specific recommendations regarding the most appropriate hemostatic agent for cardiothoracic surgery do not currently exist. So how to reduce the bleeding? We have to say multimodality approach. In the pre-operative period itself, you have to involve yourself. Iron deficiency anemia, anything is there, identify and treat it. Non-iron deficiency anemia, correct it. Check the fibrinogen level, platelet function testing. In the intraoperative period, meticulous hemostasis, minimizing the hemodilution, individual heparin and protamine titration. Previous 2 lectures we have gone. Now maintaining the normothermia, normal pH, prevention of fibrinolysis, tranexamic acid, recommendations acid. Treatment of post-operative period, we should correct if there is any fibrinogen level is low, if there is platelet level, any problem. So we have to point of care testing assessment and treat the things. So far we have seen what is recommended, what is not recommended. We'll just take a take-home message. What is recommended? Limitation of hemodilution, routine use of antifibrinolytics, transfusion of packed RBCs based on the clinical condition of the patient rather than a hemoglobin level. Packed RBCs of all ages can be used. a multidisciplinary team approach should be there. It's recommended. What is not recommended? Preoperative erythrocyte transfusion, this RBC transfusions in all anemic patients is not required. Routine use of topical sealant is not recommended. Routine use, but whenever there is a bleeding, localized bleeding, it comes under class 2B recommendation. But routine use of topical agents not advised. Similarly, antithrombin supplementation to reduce bleeding following cardiopulmonary was not required. Prophylactic administration of FFP, fibrinogen, as desmopressin, recombinant factors are not recommended. There is no role for any prophylactic administrations. These are my references. Thank you.
Thank you, Dr. Nedumaran, for this nice elaborate lecture. I take this opportunity to thank all the three speakers for delivering excellent lectures on very important topics. Welcome Dr. Benz and Dr. Lindberger. We have Dr. Nedumaran with us here, and now the topics are open for discussion. Anybody from the audience, please address your questions. Okay, I will start with Dr. Lindberger. You have mentioned about the heparin resistance in COVID-19. We have also seen some few cases of heparin resistance in case of post-COVID. And what do you think is the mechanism of why it's seen more in COVID-19, post-COVID-19?
You see, I didn't have an experience with these patients in the intraoperative period, but experience by the intensivists, by the ICU, showed that these patients has some problems, especially those who required ECMO during the pandemics. So multiple factors contribute to the thrombotic complications with COVID-19 that may result from heparin resistance. But there is another other disease that are showing this resistance to heparin, like H1N1 influenza and other types of disease. It seems to be these factors include the elevated levels of factor A8, fibrinogen, von Willebrand factor. So what it seems to happen with COVID and all, it's in parallel with these situations. Personally, I didn't manage a patient with history of COVID-19 with these problems in CPB. I have to say that here in our department, in the last 20 years, we have one case of severe heparin resistance that fortunately it was a cabbage, and the surgeons turned this to open procedure, and it wasn't even in our hospital, but here in our region of Brazil. But often we have these problems that we can, with a good protocol, institutional protocol, and the correct conduct, like more heparin, more fresh frozen plasma, doesn't go who don't have the antithrombin 3 to get through this situation. But I think specifically about COVID-19, it's more problem with the pandemics that happened during the ICU. Although much data is come to emerge about the consequences of COVID-19, and it's not a thing that we can for sure know at this moment. We see a prothrombotic state, and there are some theories linked even immune-related problem along with the anticoagulation pathway. So it seems that the prothrombogenic state is increased, and the more close the infection happened before surgery, the more this appear to exist. But we have to see more papers alongside. But I think the most important cause of COVID-19 in these situations are just here, that's in parallel with other inflammatory disease.
Yeah. Next question is to Dr. Benz. Which is the best anticoagulation monitor during CPB currently available? Which is the best anticoagulation monitor?
Yeah, that's a very good question, because the main thing is, as you could see in the survey, the ACA survey, 75% of us, to go on to the cardiopulmonary bypass, we still rely on the ACT to go on, and that remains the gold standard. To remain on cardiopulmonary bypass, we still, all of us, more than 84% actually uses the ACT. So, the answer will just be, at this moment and at this stage, is still that we all use the ACT to stay on bypass. The best monitor that we actually should use probably will be heparin levels, because the heparin levels, as well as the factor 10A and free factor 10A levels, that would be more accurate to monitor the correct anticoagulation levels on cardiopulmonary bypass. It's clearly shown that even if the ACT might be high and in a desirable level, if the heparin levels are too low and our factor 10, free factor 10A levels are too high, then we will have coagulation on bypass. We will have clots forming in the filters, and we will have, the main thing I always tell my trainees is something that, don't forget what ACT actually means. It's just a time. It doesn't mean when we anticoagulate with a patient that the blood doesn't clot on cardiopulmonary bypass. The blood just takes longer to clot. So clots still form on cardiopulmonary bypass. So the longer you stay on cardiopulmonary bypass, the more your consumptive coagulopathy takes place. And you lose clotting factors and you lose your platelets as you go along. So to prevent that from happening, it's much better to look at the heparin levels and to maintain a certain heparin level. And you've seen that on the graph where the ACT sort of divides and slides away from the heparin and the factor 10A levels. So I think those will be our best and most accurate monitors, but unfortunately, the one that we use the most is the ACT.
Thank you, Dr. Lindberger. Thank you, Dr. Benz, for participating in our conference and delivering elaborate lectures. We look forward to seeing you in our next conferences physically. Thank you so much. Take care and bye.
Thank you very much. Bye-bye.
Thank you very much.
Thank you, Nedumar.